I could kick us off then, Chief Medical Officer. Why is COVID transmission in Northern Ireland proportionately the highest in these islands? In what way is this high rate of community transmission contributing to school-aged children being the highest rate of COVID positivity of any age in our community, and therefore missing 10 days of school at a time? And what action have you taken to reduce this high rate of community transmission, to reduce that amount of time school-aged children are absent from school?
Well, thank you, Chairman. We all recognise the pandemic has been across these islands in a highly variable way as the pandemic has progressed. In the first wave of the pandemic, ourselves in Northern Ireland, the Republic of Ireland, had a very much lower prevalence of disease and impact. We then had, just last winter, a very significant increase in cases and impact, and that variability has continued throughout the recent months. So a number of weeks ago, we had the highest rates of infection in the United Kingdom in terms of case reports, and also as assessed by the Office of National Statistics in terms of their estimated cases. At one time, 1 in 40 people in Northern Ireland were estimated to be infected with COVID, compared to 1 in 75 in other parts of the United Kingdom. Now, that has now changed in recent weeks. Scotland has now overtaken us in terms of disease prevalence, as you will have seen from the R report last week, and again will be reflected in the R report when published this week. So that degree of fluctuation is an outworking of patterns of transmission, also impacted by differential rates in vaccination communities, which does vary. We know the vaccination uptake is significantly impacted by socioeconomic deprivation. We've been working very hard to address that, but we will see and continue to see higher levels of circulation in communities where vaccine uptake has been more limited. So it is just the nature of epidemics, and that variability will continue. But obviously what we know, you mentioned the second point was what we're doing. What we've been doing over the last 18 months is rolling out a highly successful vaccine campaign, and I would encourage people to still avail of the first dose of the vaccine if they haven't already, encourage people to come forward for their second dose, and encourage people to come forward for their booster dose when that gets underway in the coming weeks. What we all need to be doing is to continue to follow the public health advice. The virus doesn't spread itself, we spread it. And the picture in schools, as the Minister has said, is a reflection of the high levels of community transmission. So it's all of us following the advice around ventilation, wearing face coverings in enclosed spaces where there isn't good ventilation, good hand and respiratory hygiene, and all of those things that we know around social distancing that will make the difference. Final point I would make is that it is inevitable when you have a virus that is as transmissible as the Delta variant, as we open up society, the executive makes changes to relax some of the restrictions, that we will see significant transmission of the virus. Anyone who is not vaccinated will at some stage in the future become infected with this virus. So my advice to everyone, my plea with everyone today, is to please get the vaccine and do your bit to ensure we reduce community transmission so we can continue to have our children attending school without the disruption that we've seen at the start of the term.
Brief follow-up question to that, Chief Medical Officer. When will 12 to 15-year-olds be able to get the vaccine?
What is very important in that is the issue of informed consent. So we're now in the final stages of completing the information leaflets for parents and for children to make that informed decision about vaccination, because the risk and benefits are more finely balanced than in older adults. And we will be working very closely with the Royal College of General Practice, the Royal College of Paediatrics and Child Health, the Children's Commissioner, to ensure that we get that balance of information and consent correct. We hope to start the vaccination of those age cohorts in the very near future, certainly if not before the end of September, in early October, and the Minister will confirm the dates in due course.
Okay, I'm really tight for time here, but I'm very eager to ask you to speak about what is the new definition of close contact for school-aged children. What is the scientific and medical rationale for the change in this definition? Why it's different to the rest of the population? If you could speak about that, please.
I'll maybe ask Joanne Jane to pick that up, Chair, if that's okay with you.
The reason that the close contact definition for school-age children in school has been changed is for the reasons that Michael has already outlined. First of all, applying the definition we used before resulted in tens of thousands of children being sent home from school and having to isolate, and they didn't actually get COVID. So that's the first reason. Second reason is that what we know about COVID is that it spreads most effectively in households, and the transmission in schools is much less of a concern for us. And really, your highest risk is with household type contacts. So bearing in mind that the adult population has had an opportunity to be vaccinated, and indeed approaching 90% of the population has taken up that vaccine, the risk benefit has changed. So it is no longer justifiable to send tens of thousands of children home when we know that that will harm them in the short and long term. When we know that the adult population is protected at a stage, this time last year, that was proportionate. It's no longer proportionate. So we have moved to use a close contact definition in schools, which is much more akin to a household. So it's looking at young people who have stayed in another person's house overnight. It's looking at people who have had intimate contact. Now that can be kissing, things like that, but it can also, for staff, it can be providing personal care, that sort of thing. So we have really gone for a much more targeted approach. The reason for that is that, as I said, transmission is highest in a household type setting, and we know from experience both across the UK and locally that applying the definition we were using in the past was resulting in far too many children having to go home, missing school, and having an effect on them.
Well, why have we not differentiated between household close contacts then?
So we have. So if a child has a household close, they are treated in the same way as always, and they are asked to isolate and get a PCR test. So say for example, a child in someone's house, say I tested positive, my children who are school age are expected to isolate and get a PCR test. So children are still being treated with the household contact.
Okay, I'm almost out of time. How many school-age children that have tested negative at day 2 PCR have tested positive at day 8 PCR?
So the guidance around day 2 PCR comes from the executive guidance of the grade August. So it applies right across society. It's really important we remember that. For children, what we do is we ask them to isolate until they've had an early PCR, not necessarily a day 2 PCR, but a PCR as soon as they know their contacts. If that PCR is negative, they can then stop isolating and go to school. We do know that a small number, and it is a small number, I don't have the figures broken down for school age, but it is a small number and by no means the majority. A small number of people will go on to test positive at day 8. And there's an important safety net in all of this. The most important message that we need to give to everyone and those individuals is that if you have tested negative after your day 2 or your early PCR and you go on to develop symptoms, you should immediately then isolate and book a PCR. So yes, a small number of people do go on to test positive day 8, and that could be because perhaps they are incubating the virus and didn't have enough virus in their system initially to test positive, or importantly, it can be because they picked it up somewhere else in between. So it's important that we remember that the virus is everywhere. It's not just in schools. We all have to be careful all the time, and you can pick it up elsewhere, but it is a minority. And I have seen reports around this and concern around this, but I want to stress this is executive policy, and it is the same policy that is being operated in the rest of the UK. So and the balance of risk is in the favour of taking this.
Okay, just before I bring Pat Shane in, can I ask how will you know if you've got the balance between safety and school attendance right?
Well, obviously, let's be clear, we will continue to monitor. I do want to say that as we move through this pandemic, we have had to and will continue to have to be responsive to any new evidence and be flexible in terms of our approach and policy and guidance. And I am absolutely confident that over the next number of months that our approach and policy and guidance in schools will have to be updated and revised. That is just the nature of responding in a proportionate way to the pandemic. We will continue, and we're currently streamlining the reporting in terms of cases, positive cases in school. We'll be reporting that in the coming weeks on a weekly basis. DHA will be monitoring the situation in schools in terms of cases, clusters and outbreaks to monitor the effectiveness of the policy. What we can say at the moment is that the contact tracing of schools has been prioritised. The vast majority of parents are responding to the contacts. I want to thank parents for that, are engaging actively with the contact tracing service, and indeed the figures would suggest that that is performing well at present.
Okay, thanks for that. Pat, Shane,